It is my great pleasure to be given an opportunity to share with you about the status-neutral approach to HIV as part of this year's Asian Stigma and Discrimination Forum. And first, please let me give you a quick overview of the overall achievements towards the UN/AIDS targets by 2020. We are falling short of UN/AIDS 90-90-90 testing and treatment targets by 2020. As at the global level, we only achieved 81, 82, and 88, which equals to 59% of people living with HIV had suppressed viral load. On the other hand, we can say that still 41% of people living with HIV globally can transmit HIV to other people. And for prevention target, we have had only less than 1 million PrEP users globally against the target of 3 million people set forth. And it is very concerning to see increasing HIV incidence of plus 25% among men who have sex with men and plus 5% among transgender people over the past 10 years. And this is why it is very important for us to think about changing or shifting the paradigm of implementing an HIV program using the status-neutral approach lens. And through this status-neutral approach to HIV, once an individual is coming in for HIV testing, there will be given equal importance regardless of their HIV status. For individuals tested HIV positive, ART will be offered and initiated immediately in order to support these individuals towards the final goal of having zero risk of sexual transmission of HIV to others. And at the same time, for those who tested HIV negative, they will also be offered PrEP and PEP and condoms as part of this combination HIV prevention package immediately in order, again, to support them to find the final goal of having negligible risk of acquiring HIV. And over the past 4 to 5 years, we have seen that ART initiation has been made much more feasible through simplification of steps prior to ART initiation. And in Thailand, we have started the implementation of same-day ART in 2017 in Bangkok, and then subsequently expanded to 6 other provinces in the country. And this year, 2021, same-day ART initiation has been put into our national guidelines to recommend that any individuals tested HIV positive should have their ART initiation within that exact same day of HIV diagnosis, or at least on the first day of hospital visit if HIV testing is not conducted within the hospital. And history taking and physical examination as well as chest x-rays are the only key steps needed prior to ART initiation in order to exclude tuberculosis and cryptococcal meningitis. The blood draw for CD4 count and other baseline safety labs can be done on that day, but results can come back a few days later. But ART can be prescribed and initiated on that day. And the follow-up visits are scheduled 2 to 4 weeks after that to check on any side effects and the need for transfer to longer-term ART facilities if needed according to the health insurance schemes. PrEP can also be made same day. And the example here shown on this slide is from the Key Population-Led PrEP program, or KP-led PrEP program, in which a client who comes into a KP-led clinic located in a community setting will have counseling, have blood draw, and have HIV testing conducted by a trained lay provider. And that lay provider will then report HIV HIV test result to a doctor in a remote hospital via an online chat application. The doctor will then review test result and provide approval for PrEP prescription so that the lay provider can give out the first bottle of PrEP or the bottles of PrEP refills to the client within almost the same hour of the client coming into to the clinic to receive the service. And same-day ART initiation and same-day PrEP may sound very simple and highly feasible logistically. However, in reality, this does not work well in every setting or in every context. The example showed here is from same-day ART initiation implementation in Thailand. The left side is from Bangkok and the right side is from outside of Bangkok. And what we can see here is that among clients diagnosed with HIV who were offered same-day ART initiation, around 90 to 95% of those in Bangkok accepted same-day ART initiation, and more than 80% had ART initiated on the first day of HIV diagnosis. But at the same time, looking at data from outside of Bangkok, only 2/3 of individuals who were offered same-day ART initiation accepted the service, and only around 60% or so had ART started on the first day. And the only key difference here is that providers in Bangkok, both providers in the KP-led HIV testing clinics and providers in ART clinic, both use U=U as the motivational message to communicate with these individuals, to convince them to start and to stay on ART. And this practice may not be happening outside of Bangkok. So we will learn from our speakers today of what may be causing hesitancy among healthcare providers in communicating U=U or in integrating U=U into their clinical practices. Is it because of the low level of awareness, a low level of knowledge about U=U, or is it something related to sexual stigma and U=U? We will also learn how to overcome these challenges and discuss ways to help address these challenges. And will the inclusion of U=U message in our new UNAIDS political declaration, and maybe its inclusion in the to be launched WHO guidelines help address these concerns, or maybe we may need to write our own guidelines. And will training and creating tools to help providers communicating U=U message correctly help? Because we know that this message may be new to many people, and some people may need to take time to understand and then to trust the message. PrEP implementation also faced similar challenges. And this slide demonstrated that in a few countries in our region, key population-led PrEP program has contributed to the largest PrEP uptake at the national level. And the graph on the left side show that in Thailand, almost 60% of PrEP use have come from those people who accessed the services through KP-led clinic. In Vietnam, this proportion is more than 72%. And why there are this difference in PrEP uptake in KP-led setting and in government or facility-based setting. We will also hear more from our speakers today, whether it is something, again, related to sexual stigma and PrEP. And can the success of the KP-led PrEP program in a few countries in our region be explained by the fact that the KP-led program is designed and co-delivered by lay providers who are often members of these key populations themselves, so that the perceived, anticipated, and experienced stigma related to PrEP use may be lessened through this program. We will also learn from our speakers today around what may have hold providers back from making PrEP services be easily accessible or available, as well as at the same time, what may have hold our potential users back from thinking about accessing the services. Will something like the use of gain-framed messages in public PrEP campaign, like the PrEP in the City campaign for transgender women in Thailand, help address this concern? And at the same time, whether the use of gain-framed counseling approach, like what the Tangerine Clinic has been using, help address these concerns as well. To conclude, the status-neutral approach to HIV can change the paradigm of implementing HIV program by equalizing both HIV treatment and HIV prevention in order to end the epidemic. And it is very obvious that stigma related to U equals U and PrEP can affect uptake and retention in HIV testing, ART, and PrEP services. And therefore, innovative approaches to overcome stigma must be urgently explored through implementation science to generate more data from various contexts to feed into the development of guidelines and policies. Each of us has our own role to play here, so please stay tuned to learn what we can do. And I would like to end by acknowledging our funder and implementing partners and colleagues listed here. Thank you very much.